Bueno, muy buenos días a todos. Mi nombre es Daniel Motola, yo soy oncólogo médico del Hospital Médica Sur. Para mí es un verdadero honor estar aquí en el instituto y ver este excelentísimo simposio. Agradezco mucho a la doctora Ruiz y al doctor Melchor por haberme invitado a coordinar esta parte de carcinoma hepatocelular, que es un tumor muy interesante, con el advenimiento de las nuevas moléculas, no nada más de la inmunología, que obviamente viene a cambiar el tratamiento sistémico de este tipo de tumores, sino también de otras moléculas como los inhibidores de tirosinosinasa, que fueron los primeros que realmente mostraron algún beneficio en este tipo de tumores. Y bueno, para platicar de esto y de qué es lo nuevo que tenemos para el tratamiento de este tumor, que sí vemos muchos pacientes en nuestro país, invitamos al doctor Abu Alfa. Gracias por venir aquí a México y por darnos esta plática. Welcome to Mexico.
I am terribly sorry that my Spanish is what you're hearing now, that's all. But thank you again for having us, thank you. So, as we heard in the introduction, liver cancer is really probably exactly as you decided to call the lecture state of the art, and it's evolving extremely fast as we heard in the introduction. These are my disclosures, and these are my contacts. If you'd like to take a picture, or I'm happy to reach afterwards and happy to provide them with my card as well. So that's really kind of like in brief what we're talking about, and we're addressing specifically systemic therapy for liver cancer, and that's really how the map looks like in the United States. I know that things differ in other countries, including Mexico, for the approval of certain drugs. But bottom line, we have sorafenib and lenvatinib in first line. In second line, we have regorafenib, cabozantinib, ramucirumab, nivolumab, and pembrolizumab. And then we have in third line cabozantinib as well. I can very easily do the lecture by starting, okay, let's talk about this after the other, but understandably, since last December, just 2 months ago, the data that was reported at ESMO Asia in Singapore about the combination of atezolizumab plus bevacizumab was very disruptive. This was, as you all know, was called the UMBRAVE study that randomized patients with advanced liver cancer to atezolizumab plus bevacizumab versus the standard at that time, sorafenib. And as you can see over here, the median survival for the atezolizumab plus bevacizumab was not reached yet, and the sorafenib had a median survival close to about 13 months. So no question that this was looked at as being a potential new standard of care, and if anything, we could easily see the map changing to a first-line atezo plus bev. And then the question will be, shall we move everything by one step down? In other words, the sorafenib plus lenvatinib become second line, and then the 3 TKIs and the 2 checkpoint inhibitors become third line, and then cabo become fourth line. That's one thought. Interestingly, it might be a little bit more complex than that, because what we have thought that the combination of the atezolizumab plus bevacizumab, which is mainly driven by the fact that anti-angiogenic or anti-VEGF, like bevacizumab, as you can see at the number 6, will induce or enhance the activity of anti-PD-L1, anti-PD-1, like, for example, bevacizumab. However, it can be a little bit more complex than that, and one at least reflection, not necessarily a critique, but a reflection, is that the progression-free survival for the atezolizumab plus bevacizumab has not really been so far up to the expectation of extremely being very high. As you can see, it's really rather limited, with only about 6 months and versus 4 months for the sorafenib. It brings in question is, could it be there could be other approaches to do the same thing, i.e. to tackle the immune system in a more effective way? And one of them is looking at a combination of a TKI, being lenvatinib itself, plus, again, pembrolizumab. And this data was recently reported by Dr. Love. And as we can see here, the responses are definitely up there. Now, this is actually currently in a phase 3 trial. We don't have the results yet, the LEAP-002 study. And we'll see if potentially a quote-unquote less toxic drug like lenvatinib might do the job, quote-unquote, probably better or the same or maybe worse than what bevacizumab has done in regard to the atezo plus bev. We don't know yet. We just have to wait and see. And of course, there's another component of this story. I'm not an immunologist, so I really have to go to the basis to learn for myself. And I'll share with you that our best understanding is what anti-PD-1 does. I would like you to think about it as being simply a chair and is sitting holding the T cell right above the T cell surface. And if anything, the anti-PD-1 will do is simply kick that chair out and the T cell can fall onto the tumor cell. Interestingly though, this does not happen except if a phone call is taking place where at the lymphocyte level upstairs, in other words, get the command, because if we know CD80 and CD86, they are actually good friends with another molecule CD28, and they kind of like energize together, and they really, let's say they have very strong coffee, and they talk to the anti-PD-1, the correction to the PD-1 at the tumor cell level, and make it cause its effect. Interestingly though, there is another molecule that comes into play, CTLA4, which if anything, a nice guy, if anything, will convince CD86 to hang with them. And they don't drink coffee, they drink tequila. And they actually fall asleep. And if anything, this is where anti-CTLA4 come into play, stopping the CTLA4 from kind of activating itself, and as such, induce more of that activity. We're not sure yet, again, if this is a mechanism that will be as important or more important than what we have seen so far. But if anything, the Himalaya study, which has been a worldwide study, 1,200 patients, looked at durvalumab as an anti-PD-L1 by itself versus durvalumab anti-PD-L1 plus tremelimumab anti-CTLA4 versus sorafenib. We know that this was reported to have completed, but we don't know the results yet. We're just waiting to see what will take us there. As you can see, in other words, it's not only about atezo-bev. There's much more combinations that I probably will split into 3 types. The anti-angiogenic, like bevacizumab, the anti-TKI, like lenvatinib, and the anti-CTLA4, like the tremelimumab. And we just have to wait and see how this will define things moving forward. Now, why more? And if anything, the perspective of like we add even 3 together. So if anything, a study that those of you who were at GI ASCO in San Francisco last month looked at the data of nivolumab, ipilimumab, and cabozantinib. Again, a anti-PD-1, anti-CTLA4, and a TKI being cabozantinib. The results definitely quite intriguing, but one component that really drew the attention of everybody is rather if you focus on the adverse events, you'll see that there was a very high number, more than 70% of patients who had grade 3 adverse events. So I'm not sure where this triplet combination will kind of play or it will become a standard. We just have to wait and see. So that's really all what's going on at the moment in regard to the very near future. The question is where we go from there. And that's really why I go back to kind of a little bit of a redefined map. And I would say that rather than pushing things down and move them along, let's think about it as being like line -1. And I would say a triplet, or rather a combination, will be where the future is going. Which one, we'll have to wait and see. And then after that, we'll still keep the line 1 and line 2 and line 3 as they are. Because after all, the point of view is these were very heavy investments. A lot of patients really sacrificed their time and efforts to be part of those studies, and we know those drugs worked and they helped people, and it will be worth to kind of like see that they could be valuable still for patient care. So within that context, of course, the first line is sorafenib. If anything, sorafenib, we proudly started it as a phase 2 study back at Memorial. Actually, I give credit here, our colleague here and friend Dr. David Witzel, who was at that time with us at Memorial when we were doing that effort. And then this led to the phase 3 trial, as you know, the SHARP study, which showed improvement in survival and led to the drug become the standard of care for all of us in Mexico, everywhere else. What I call kind of like coming from the left field, in other words, not expected, there was a study of a drug which, quote unquote, very similar to sorafenib, called regorafenib. There is a certain variation between the two, and if anything, a certain study, if you recall, looked at regorafenib versus placebo after progression on sorafenib. Patient had to progress on sorafenib, tolerate sorafenib, and they get regorafenib. And again, it was positive, as you can see over here, with an improvement in survival, and if anything, intriguing enough to become another standard of care as a second-line therapy with conditional pre-exposure and tolerance and progression on sorafenib. Now, in exploratory analysis that was retrospectively done, they looked at the combination of the survival in a retrospective fashion, so there's a little bit limitation here, to the combination of sorafenib followed by regorafenib. And as you can see, for the first time ever, in regard to systemic therapy, we're talking about more than 2 years median survival, 26 months. That's quite intriguing, and if anything, really, it could be inviting to the idea of sequential therapy. And by the way, it's not the only one. If anything, lenvatinib came into play. We know that the design for the study was a non-inferiority, and especially for the fellows and trainees, non-inferiority doesn't mean, oh, I'll just see if it's equal and then move on. It's a statistical design specific by itself to ensure that we're specifically answering if it's not worse. That's all what we're looking for. So as such, if you have the two curves like hugging each other, like what we're seeing here, that's very good. That's really what you want. Interestingly, the lenvatinib versus sorafenib on the progression-free survival showed a certain improvement, about 3 times higher for the lenvatinib. And data that, if anything, was just reported at GI ASCO, which is rather intriguing, is the subsequent anti-therapy can actually improve survival if lenvatinib was in the sequence. And this is actually looking at all different therapies, as you can see, favoring lenvatinib. But more intriguingly, if you look specifically at the patient who received the lenvatinib because they had systemic disease and they continued on other systemic therapy, interestingly, their median survival was pretty high, 27 months. And interestingly, they could not calculate it for the sorafenib because nobody was alive then. So no doubt this is another intriguing point in regard to the lenvatinib / its value in regard to the sequencing of therapy. Now, the checkpoint inhibitors came into play in regard to liver cancer relatively late compared to melanoma and lung, because there was always a fear or a concern about the activation of the virus in regard to liver cancer if it was virus-driven like hepatitis B or hepatitis C. And ultimately, certain early tests did happen. It started with tremelimumab, actually, with Dr. Bruno Sangro in Spain. And after that, it followed with nice work by our colleague, Dr. Al-Kuwairi. And as you can see over here, the duration of response was really the key element that there was an interest in. If anything, if you ask the FDA, why did they approve nivolumab, based, even though we don't have phase 3 data, they tell you they were interested in the duration of response. People can really stay on the therapy therapy for a long period of time, as we can see. Despite that, actually afterwards, checkpoint 459, which is nivolumab versus sorafenib, looking for superiority, that was published at ESMO in Barcelona last September, was negative. And after all, no matter how you look at it, it was not a positive study. It did not really show us that there's any improvement in outcome compared to sorafenib. Pembrolizumab was not any better. If anything, again, from our dear colleague, Dr. Zhu, the pembrolizumab, again, was approved based on the duration of response based on the phase 2 data. And surprisingly, the phase 3 trial of pembrolizumab versus placebo in second line in HCC was negative too. And one might wonder that after all, checkpoint inhibitors as an anti-PD-1 by itself is not enough, and that's why the combination is critical. And of course, then moving forward with the TKIs came the study of cabozantinib, which again showed an improvement in survival compared to placebo. These patients required prior sorafenib, admittedly by default, because this was the only thing that was available, and at least sorafenib, because even patients who had 2 prior lines of therapy, at least one of them sorafenib, were allowed on the study, and that's why we put it as a potential third-line therapy as well. The third TKI in, or rather non-checkpoint inhibitor, which is an anti-angiogenic, ramucirumab, in second line in HCC, was looked again versus placebo. If you recall, the study was done beforehand, it was negative, but then they identified in a pre-planned way that patients with a high alpha-fetoprotein more than 400 did fare better, and that's why they repeated the study. Was called REACH2 and looked specifically at the patients with a high alpha-fetoprotein more than 400. And again, they showed an improvement in survival, as you can see here, even though not to the same extent as it is for the patients in the other trials like cabozantinib or regorafenib, etc. And one might wonder if the AFP is really a true prognostic or even a diagnostic marker, because we know that any irritation of liver or inflammation can cause in a high AFP, and is not really a sole driver for liver cancer per se. So as such, we'll conclude that the combination therapies at the moment are novel, they are positive, and they're disruptive. They are changing the whole plan, and I can't tell you what the new plan is going to be. I already showed some models of it, but at the moment there are 3 types. As I said, anti-angiogenic plus the checkpoint inhibitor, the TKI plus the checkpoint inhibitor, and the double checkpoint inhibitors like the tremelimumab plus durvalumab. Sorafenib and lenvatinib are appropriate and acceptable first-line therapies at this point in time until we see how this disruption will occur. In regard to lenvatinib and sorafenib, clearly there is an improvement in the overall survival, progression-free survival response rate, and even extensive of duration of response if we continue after lenvatinib, as we showed, even better than what we saw with sorafenib. Regorafenib, cabozantinib, and ramucirumab are approved second-line therapies, at least in the US. And I would say the future of the nivo and pembrolizumab, because this is a classic question we get asked, what's going to be? I would say the FDA will not take away the approval. And the question is going to be, however, if a patient got prior exposure to a combination, let's say lenvatinib plus pembro, after an exposure to certain TKIs, can they respond again to a checkpoint inhibitor or not? We don't know. We just have to wait and see. With this, I'll thank you very much for listening, and thanks again for the invitation.